I'm Dr. Fakir Abadi, and this is Clostridioides difficile infection in adults. Clostridioides difficile, or C. diff, was formerly known as Clostridium difficile when nomenclature changed in 2018. C. diff is a gram-positive anaerobe, and it has two important characteristics. The first one is that it's spore-forming. It can survive in aerobic conditions by forming spores, and alcohol rubs are ineffective against spores, which makes washing hands with soap and water extremely important. Spores are stable in acidic environment as well, such as the stomach. The second aspect of C. diff is that some strains are toxigenic, meaning that they can produce toxins. Specifically, C. diff, toxigenic C. diff, can produce toxin A and toxin B. And I'll explain what the consequences of these toxins are. C. diff infection is extremely important because it is attributed to extreme healthcare costs, as well as 5% infection-related mortality and 15 to 20% all-cause mortality. In fact, the CDC has classified C. diff as an urgent level of threat because of its prevalence and associated death. Although the rate of C. diff has been going down in recent years thanks to antimicrobial stewardship efforts, the annual cases requiring hospitalization are still in excess of 200,000. Now, to demonstrate how prevalent C. diff is, you can see the rate of C. diff on the left-hand side compared to the rate of ESBL infections, which is much more common than multi-drug resistant Pseudomonas, which is more common than carbapenem resistant Enterobacterales, which is more common than carbapenem resistant Acinetobacter. So you can see that C. diff infection is a serious infection that's very prevalent. And to make things worse, it is also associated with increased rate of death, and you can see that the rate of mortality from C. diff is significantly higher than mortality due to ESBL infections, which is significantly higher than multi-drug resistant Pseudomonas, which is higher than CRE and CR Acinetobacter. Let's take a look at the pathophysiology of C. diff infection. It requires both acquisition of C. diff as well as disruption of the gut microbiota, because the gut microbiota has a protective role against C. diff. Although the exact mechanism of symptomatic infection is unclear, toxins play an important role. The toxins produced by C. diff can disrupt the epithelial cells inside the GI tract, which can result in release of inflammatory mediators, and this immune response can be severe in many patients. In fact, the clinical manifestations range from diarrhea to pseudomembranous colitis to toxic megacolon, colon perforation, and death. As I mentioned, the healthy gut microbiota have protective role against C. diff. When patients are exposed to antibiotics, the normal gut microbiota is disrupted. This leads to decreased species abundance as well as decreased diversity in the gut microbiota. In patients with disrupted gut microbiota, the C. diff spores find the opportunity to germinate to vegetative cells, and then they can grow and dominate the GI tract. And then once C. diff colonizes in the colon, some patients may remain asymptomatic. That depends on whether their immune system will respond to toxins produced by C. diff. For some patients, these toxins will induce an immune response, and depending on the severity of the immune response, there can be serious consequences, such as hypotension or shock, ileus, or toxic megacolon. These patients are the most difficult to treat and have the highest risk of mortality or need for surgical intervention to manage CDI. When patients receive treatment with antibiotics for C. diff infection, the clinical symptoms will be resolved. Over time, the healthy gut microbiota will be restored, protecting the patient against future C. diff recurrences. However, if the gut microbiota continues to be disrupted, then the patient will be at risk of getting recurrent C. diff infection. Alright, let's take a look at how someone acquires C. diff infection. So, initially someone is C. diff negative, and when this person gets exposed to the healthcare setting, they are immediately at risk of acquiring Clostridioides difficile. And one thing that can happen is that this person can actually acquire non-toxigenic variant of C. difficile. And of course, because this non-toxigenic, this patient will not have symptoms. So this will be an asymptomatic colonizer. Another thing that can happen is that someone can be exposed to toxigenic variant of C. diff, and their immune system can actually mount immunoglobulin G response to the toxin A. And because this immunoglobulin will actually neutralize the toxin, this patient also will not have symptoms. So this patient will be asymptomatic colonizer. A third option is that when someone is exposed to toxigenic C. diff, their immune system cannot mount immunoglobulin G response to the toxin. And because the immune system cannot neutralize the toxins will develop symptoms. So this will be symptomatic C. diff infection. Now, all three of these can transmit C. diff to other people, especially if they are asymptomatic and they get discharged home prior to being treated. Now, with the initial case of asymptomatic colonization with a non-toxigenic, this is not a problem because this is pretty benign, this strain of C. diff. The problem is with the toxigenic C. diff. So someone who's asymptomatic can go home and transmit this to other people like family members or friends, which can lead to community transmission of C. diff. And this symptomatic C. diff, of course, will be treated and will be in isolation to have infection control. Although healthcare and chronic care facilities have been typical places in which patients acquire C. diff infection in the past decade, more patients are presenting with community-acquired C. diff infection. Now, let's take a look at reliable resources. So in general, we have IDSA and ACGs, American College of Gastroenterology, have recommendations for C. diff infection. In 2017, IDSA actually released a guideline for infectious diarrhea. This is for management of infectious diarrhea due to other causes other than C. diff. So C. diff is not included in this guideline. But in 2017, they also released a guideline specifically for C. diff infection. So any diarrhea due to C. diff. This was in collaboration with Shea. Recently in 2021, ACG, American College of Gastroenterology, also released updated guidelines for C. diff infection. And these guidelines are actually in agreement with the 2017 IDSA guidelines. And then shortly after ACG guideline was released in 2021, IDSA also released a focused update, which basically updated 3 recommendations. So this is a supplement to the 2017 IDSA guidelines. So there are a lot of recommendations in 2017 guidelines, and this focus updates basically as 3 recommendations or updates a couple of old recommendations. And lastly, there is a 2020 guideline from American Gastroenterology Association, specifically for the role of probiotics in the management of GI disorders. The first learning objective is describe the PK/PD properties of antibiotics used for CDI. Metronidazole essentially disrupts the DNA and inhibits nucleic acid synthesis. It is available both as IV and PO. Note that with the PO, it is 80% bioavailable. Now for CDI, the site of infection is actually in the GI tract. So it's actually best if the drugs are not absorbed, because when they are absorbed, they go away from the site of infection. So when 80% of oral metronidazole is absorbed, about 20% of it stays in the site of infection. And of course, with IV, 100% bioavailability means that the entire drug goes into the bloodstream, and then a portion of it may actually go from the blood to the GI tract. One adverse effect that's unique to metronidazole is that the patients might get metallic taste. Now, this is specifically with the oral formulation, not with the IV. For vancomycin, we have two oral vancomycin formulations. So we have vancomycin, which is basically a capsule, and we have more recently Fervanc, which is an oral solution. Now, because these oral formulation of vancomycin are very expensive, we actually in the hospital, we can use the IV formulation of vancomycin as oral because the IV formulation, which is meant for injection, is quite inexpensive, can actually give it orally. But regardless, for treatment of C. diff infection, vancomycin must be administered orally. So IV vancomycin as an injectable is not an option. And this is really important because pretty much less than 1% of vancomycin is absorbed. So it actually stays at the site of infection. So this is excellent. Now we also have fidaxomicin, which is available as an oral tablet. This also does not get absorbed, so it stays at the site of infection. We also have rifaximin, which is also not absorbed. And more recently, we've had bezlotaxumab, which is a human monoclonal antibody, which basically binds to the toxin B, and it prevents the toxin from having its effects on the cells. And this is specifically IV, and I'll explain more about this. Now, one thing that's important about bezlotaxumab is that heart failure was actually reported more commonly in the patients that received this agent in patients with a history of congestive heart failure. So in patients with a history of CHF, bezlotaxumab should be reserved for use when the benefit outweighs the risk. And this is from the package insert. Now I want to draw your attention to the fecal concentration of these drugs because the site of infection is in the GI tract. You will see that because oral metronidazole is mostly absorbed, you get the significantly lower concentration in the feces, and this is in microgram per gram of the feces. Whereas with vancomycin and fidaxomicin, you get significantly higher concentration. So I want you to keep that in mind when we talk about the efficacy of these agents.